Hi everyone, welcome to your Fertility and IVF Options webinar. My name is Laura and I'll be your host tonight. Thank you for joining us and we hope we can provide you with some insight on fertility, the IVF process and options available to you. Previously known as Sydney IVF, Genea has been at the forefront of IVF treatment and creating families for more than 37 years. We have over 57 fertility specialists and 14 clinic locations throughout New South Wales, Canberra, Melbourne, Perth, Brisbane, and now Adelaide. Genea offers a wide range of fertility treatments with our dedicated fertility specialists developing tailor-made treatment plans for your individual needs. Our unique care model means you have a dedicated team of nurses, scientists, and counselors, all tailoring treatment for you. You'll also have the same fertility specialist throughout treatment and be provided with access to 24/7 on-call medical support. I'd like to now introduce fertility specialist Dr. Anthony Marren and Canberra embryologist Erin Gerdsen, who will be taking you through the presentation. Dr. Anthony Marren understands the emotional journey couples endure when they have difficulty conceiving or experience recurrent miscarriage. He appreciates the importance of listening to his patients' concerns and providing support during consultations. Anthony strives to offer clear, helpful information in order to empower his patients to make informed decisions regarding their fertility treatment. In addition to IVF, Anthony is a skilled laparoscopic surgeon specializing in complex surgeries such as endometriosis, fibroids, and tubal reversals. He has a specific interest in the investigation and management of recurrent miscarriage, recurrent implantation failure, and pre-implantation genetic testing. He's also experienced in fertility preservation for men and women about to undergo chemotherapy. Anthony offers comprehensive, evidence-based female and male fertility treatments 6 days a week in his St. Leonard's and Sydney CBD clinics, open Monday to Saturday for consultation. Our Canberra embryologist, Erin Gerdsen, has a passion for using her knowledge to help our patients from within the laboratory, taking care of their eggs, embryo, and sperm. She has studied a Bachelor of Biomedical Science and in 2022 has started to study embryology. Erin previously worked with our donor team and genetic counseling team. We'll get started with the presentation now, but please feel free to ask any questions by submitting them via the Q&A button on your screens. And if you're joining on the Facebook Live, please place those questions in the comment section and we'll be sharing these at the end of the presentation. Now over to you, Anthony. Thank you.
Thank you very much for that introduction. So look, basically what we're just going to run through today is a little bit of background in regards to infertility and specifically the importance of female age, a variety of treatment options, so not just IVF. We will go into a fair amount of detail in IVF, both clinically and also then what happens in the lab, and then also next steps. So firstly, what is infertility? So essentially, if you look at couples who are trying to achieve a pregnancy, what you'll basically sort of find is that at 12 months of trying to conceive, about 83% of couples will be pregnant. It begins to plateau, and so then it's about 92% at 2 years. And then it has completely plateaued, so it's then 93% at 3. Now, that doesn't mean to say that couples who have been trying for 3 or 4 years can't achieve a pregnancy, but statistically, it's pretty unlikely. And the majority of couples will get there within about 6 to 12 months. So we sort of define infertility. So, sorry, can you just go back? We sort of define infertility where a couple have been trying for about 6 to 12 months and they haven't been successful. In our young population, so those that are less than 35, we're usually happy for them to try up to about 12 months. And that's just largely because they have more time to sort of try and achieve a pregnancy. And for those that are over 35, we're usually sort of keen for them to seek help a bit earlier. So at any more than 6 months. And that's just because we're a bit worried that, they might sort of run out of time. Now, obviously, if there's any known specific fertility problems, such as previous issues with the tubes or male factor or something like that, then we would ask people to seek help sooner. Next slide. Yeah. So the impact of age. So look, female age is particularly cruel from a fertility perspective. And so this graph here just basically shows the monthly probability that a couple will achieve a spontaneous pregnancy based on female age. And so you can sort of see that when someone's young, so in their 20s or early 30s, it's somewhere between about 20 and 25%. And there's this gradual decline down to 35, and then it's a much sharper decline down. And essentially it's due to a number of factors. So there's a decrease in egg numbers, but what's more important is that there's a decrease in egg quality. And what we really sort of see is we basically sort of see that the rate of random chromosome error in the eggs goes up. And so this leads to higher rates of chromosomal errors in embryos, and therefore it's less likely that they will implant, and it's more likely that they will miscarriage. To give you a bit of an idea, when we do chromosome screening in our IVF cycles, for our young patients, so less than 35, the rate of chromosome error in those embryos is roughly about 30%, which a lot of people are quite surprised at how high that is. But it jumps to about 50 to 60% at the age of 40, and then it's about 80 to 90% at the age of 43. Next slide, please. So what can go wrong? So essentially, infertility is broken down to largely male factor, female factor, a combination, and then unexplained. From a female factor perspective, there can be ovulation problems, tubal issues, problems with the uterus, endometriosis, and things like that. And then, of course, there's also the potential for sexual dysfunction on one or both sides. Next slide. Now, the more fertility factors that there are, then the longer it will take a couple to get there. So this is just basically trying to sort of say that if you have a couple and they're investigated and everything's completely normal, then they're likely to get there quite quickly. And this slide says roughly about 3 months. If there's a single factor, so for instance, there might be damage to a fallopian tube or something like that, then it might take a little bit longer, say 2 years. If there's 2 factors, such as damage to a fallopian tube and some abnormal semen analysis, it may take 7. And then obviously, if there are multiple factors going on, then the probability that a couple will get there is very, very low. Next slide. Lifestyle is very important. And so the main things that we're really sort of talking about is like smoking, caffeine, alcohol, nutrition, and stress. And there's very, very good data, particularly with smoking. It's really associated with an early onset of menopause. So there's no doubt that it has negative impacts on egg numbers and egg quality. It's very much associated. It's very much associated with impaired sort of sperm production and quality. Alcohol also has these issues from a fertility perspective, but one of the other main things that we're particularly interested in is the fetal effects. And so certainly the federal government, their sort of line at the moment is that anyone that is wanting to achieve a pregnancy probably should not be drinking at all in the lead up to a pregnancy and then throughout. From a nutrition and weight sort of perspective, what we basically sort of see is both being underweight and overweight is actually really important. So underweight often leads to ovulation problems, whereas being overweight can also lead to ovulation problems. But the other thing that we sort of see is that as BMI goes up, there's probably some inflammatory chemicals that's released by the fat cells, and that has a negative impact on egg quality. Stress is really, really difficult. It's very hard to measure stress and to truly sort of work out the impact on fertility. The data from a fertility and a miscarriage perspective is not sort of clear cut, because it's hard to know, is it the stress causing the fertility problems or vice versa? But there's no doubt that managing stress is important sort of moving forward. Next slide, please. So what are the treatment options? So basically what will happen is there's obviously there's an assessment process, but in terms of just going through them, sometimes we do just some very simple things like tracking ovulation. So if someone's cycle is a little bit irregular, they're not quite sure the right time to try, then essentially just some simple tracking can often be enough just to get people over the line. In those women who aren't ovulating, then ovulation induction is helpful. Likewise, if there's some mild male factor or there's issues from a sexual dysfunction perspective, IUI is helpful. And we'll talk a lot more about IVF and ICSI down the track, and also the chromosome and genetic screening. Next slide, please. So the first step is basically an assessment. And so that's either sort of done with your GP, or Genea has some GPs that sort of work with us. And essentially, there's usually some tests, blood tests, ultrasound, and sperm tests. So there's basically tests that are done on both sides. And there's also some genetic sort of screening tests. At the moment, there is actually a New South Wales government rebate where they are actually rebating for $250 for fertility tests as a couple. And then depending on what that sort of shows, so if everything is normal, the GP may just get people to continue to try, or they might try something simple like ovulation tracking, or they'll sort of refer on if patients have been trying for quite a long time, or there's obvious issues. Next slide, please. So ovulation tracking, so as I said, timing is important. It's basically a series of blood tests. And so what we generally say is that if someone's got like a 28-day cycle, and this is like the textbook cycle that people talk about, then ovulation is often around about day 14. And that's because the time from ovulation to the time the period comes is roughly about 2 weeks. And essentially what we sort of know is that an egg has to be fertilized within 12 to 24 hours, and sperm can last for around about 3 to 5 days. So if someone does have a regular 28-day cycle and ovulation is occurring on day 14, then the optimal time to try is between days 10 and 16. And we would normally get people to be having intercourse roughly every 2 days around that time frame. Where the tracking can be helpful is for those women where there's a little bit of variation in the cycle. So it often just pinpoints exactly when ovulation is, so that they can be right on time in terms of having intercourse, and particularly if they then need to take the next step, and if they need to sort of take the next step and do some fertility treatment. Often a lot of people like to be completely reassured that they've definitely been having intercourse at the right time. Next slide. In terms of ovulation induction, so this is really a treatment for those women who aren't ovulating. So it's not a very good treatment for women who are ovulating. And in actual fact, if you look at cumulative pregnancy rates, the pregnancy rates are roughly the same. It's just that those that actually do achieve a pregnancy with ovulation induction, they're more likely to be sort of multiple pregnancies. So essentially it's for those women where the partner has normal sperm, the tubes are open, but they're not ovulating. And it's usually by some oral medication, and the most common medication that we use is something called letrozole. As opposed to cycles tracking, which is just blood tests, we also do ultrasounds to basically just make sure that there's one and no more than 2 follicles appearing. If there's 1 follicle, we tell people when to have intercourse. If there's 2 follicles, we sort of warn people about the risk of twins. And if there's any more than 2 follicles, we sort of cancel the cycle. And that's the biggest risk with ovulation induction. Next slide, please. So IUI, as I said, it's usually for those where the male has mild male factor. So not moderate or severe, but it's mild male factor. Or in cases where there's some sexual dysfunction. Sometimes there might be cases where the male is away for long periods of time, like they might be in the Army or the Navy and they're away for months at a time. And obviously we also use it in the donor sort of setting. If the woman's ovulating, there's no need really for the woman to take any medication at all. And essentially we just work out when ovulation is, and then we bring the woman in, and it just depends on whether or not we're using fresh or frozen sperm. But the scientists prepare the sperm, and that's injected through the cervix into the uterus. So the procedure is fairly minor. It's like having a pap smear. And we do that at the right time. And with intrauterine insemination, and the same with ovulation induction, what we would be aiming to do is to try and achieve the monthly pregnancy rates that the couple would expect if there was no underlying fertility problems. Next slide, please. So egg freezing. So it's not the main topic of tonight's discussion, but it's probably just one thing to sort of say is that some women will choose to try and sort of preserve their fertility. And that's really sort of broken down to medical reasons or non-medical or social reasons. So medically, some women may choose to preserve their fertility either because they're going to be exposed to chemotherapy, radiation therapy, or other medications that are going to harm the ovaries. Or sometimes it can be because they've had surgery on an ovary, and there may be other sort of surgeries up and coming, and they're worried about diminished ovarian reserve. The non-medical or social is largely where women have reached a certain stage in their life and they haven't met a partner and they can't foresee themselves having a pregnancy in the very near future, but they very much want to preserve the capacity to achieve a pregnancy. And so people will basically freeze eggs in that situation. And the main thing to say about egg freezing is that what you're doing is you're freezing the genetics of a younger egg so that it can be used when someone is older. Next slide, please. So just going through IVF. So IVF is this sort of general term that we sort of use that sort of encompasses all the medications and blood tests and ultrasounds and procedures and things like that. But the term also specifically refers to how we bring egg and sperm into the together in the lab. And so if the semen analysis is normal, we would normally do standard IVF where you put sperm on top of the eggs. Whereas if there's an issue with the sperm, then we'll do ICSI, which is a technique where we inject sperm into the eggs. But you'll hear IVF gets used a couple of different ways. Next slide, please. And next slide. So the first step of an IVF cycle is stimulating the ovaries. Now, in terms of the image on the left, this is an ultrasound of an ovary of a woman just going through a normal cycle, so not an IVF cycle. And essentially what this basically sort of shows is that a woman is slowly releasing eggs in these little tiny black areas, what we call follicles. And the normal number of follicles per ovary is between 5 and 20. And what will happen is that each month, one of those little follicles will grow and become large and eventually ovulate. So let's say someone's got 10 little follicles on their left ovary and 10 on their right. Then one of those 20s will actually sort of ovulate, and the other 19 will just die off. So that woman will lose all 20 eggs, even though she only practically uses one. And in an IVF cycle, we just really exploit the fact that she's got all of those other little follicles there. And our medication just basically tries to make as many of those little follicles grow as possible. And as a bit of a rough rule of thumb, we can make about half of them grow. Now, what's really important is that, as I said, we can't make new follicles appear. So if someone has a very low ovarian reserve, like let's say someone's got sort of 3 follicles on their left and 3 on their right, then in reality, we're probably only going to be able to get 3 or 4 to grow. And so that's just really important that people understand that from a setting expectations. The image on the right shows a stimulated ovary with IVF. So you can see that those follicles now are all quite large. And essentially, we would hope that each of those large follicles contains an egg, and that we'll be able to go on and collect those eggs in an egg collection cycle. Next slide, please. In terms of the actual egg collection process itself, so in terms of the stimulation, as I said, there's normally about 8 to 12 days of injections. And in that time frame, there's 2 to 3 sets of blood tests and ultrasounds. And when the follicles are large enough that they're likely to contain a mature egg, that's when we say, right, this is when we're going to do our egg collection. It's the main procedure. It takes roughly about 30 minutes, and it's a day procedure. So 50% of people will take that day off work, and 50% will take that day and the following day off work. It's a bit clinic and also doctor dependent. So most clinics put everyone to sleep for the procedure. At Genea, it's a bit doctor dependent. So some doctors put everyone to sleep. Some of us give patients the option in terms of whether or not they want to go to sleep or whether or not they want a little bit of sedation and local anesthetic. But essentially, the ovaries sit down beside the cervix and on top of the vagina. We insert our ultrasound probe, so the image on the right. So you can see an ultrasound probe there with a needle on top. And our needle goes through the top of the vagina into the follicle, and we drain the fluid in that follicle, and that fluid goes across to the scientists, and they retrieve the eggs. And basically, we go from one follicle to another, and we do both sides. And as I said, most people will remain in the day surgery about an hour afterwards, and then they'll sort of go home. The day of the egg collection, we call from an embryological perspective, day 0. Next step, please. The second thing is obviously not only do we need eggs, but we need sperm. And so essentially most of the time, the male will provide sperm via an ejaculated sample in the clinic. Sometimes we need to get sperm from the testicles, so either via a needle and aspirate, or sometimes a more formal open biopsy. Next slide, please. I'm just going to hand over to Erin now, and she's going to talk through some of the lab stuff.
Good evening, everyone. So my name is Erin, and I am an embryologist here in Canberra. So this evening, I just want to walk you through the role of an embryologist throughout your cycle and just provide an overview of what happens throughout the lab. So basically, the day before your egg collection, an embryologist will give you a call to talk you through what to expect from the procedure and just to confirm that we are all on the same page about your upcoming cycle. Oops, sorry, I just realized that my video was not either, so apologies for that. So yes, we'll give you a call to let you know what to expect from the procedure and just talk about your upcoming cycle. We'll also just let you know when to expect phone calls from the lab following the days following your egg collection. And it's also just a really good opportunity for you to ask any questions if you're not quite sure about what's going to happen during the process. So just going a little bit ahead there. So on the day of your egg collection, so we, the embryologists, will be in theatre with you. So as Dr. Marren was saying, as he and our other fertility specialists drain the fluid from your follicles, we'll actually be going through that follicular fluid and searching for your eggs. So if you are awake in the procedure, we'll actually be able to see a picture of your first egg. We'll show you up on the screen. And a picture of this is actually shown on the bottom right-hand side of this slide as well. Now, after your procedure, I will also come and have a chat with you. We'll let you know how many eggs we have been able to collect. And we'll also just give you an indication of how the sperm has washed up in the lab as well. So when we do receive the sperm in the lab, basically we wash the sperm, and that allows us to select for the sperm that are swimming well. So if there are lots of sperm that are swimming nicely, basically meaning that we have a good concentration and good motility, we will proceed with IVF as a method of insemination. So if you look here on this video on the left-hand side of your screen, this is a little indication of what happens, which is basically we just pop the eggs and the sperm into a dish together, and we leave them overnight for insemination. Now, if there are any question marks over the quality of the sperm, so maybe there's not enough sperm, or maybe the sperm just aren't moving quite well enough, we do have ICSI as an option. So if I play this video on the right, basically what you'll be able to see is what we do is we select the sperm, and then what we'll be doing is injecting a single sperm into each mature egg. So it's a bit of a slow video. This part here is just the immobilizing the sperm. And then next we will see it being injected into the egg. Okay, now the day following your egg collection is what we refer to as day 1. So it's at this point that an embryologist will give you a call and just to let you know how many of your eggs have fertilized. Now, what we're looking for in our fertilization check are these 2 little discs inside of the embryo. So these are called pronuclei. So you can see these in the picture under day 1. And basically what these mean is that we can see that both the sperm and the egg have activated. Now at 7 p.m. on the night of your fertilization call, you'll also be able to register for our Grow app and have a look at your embryos online. And that's something that I'll talk about in a bit more detail shortly. So then we just leave the embryos to grow and divide until day 3. Which is when we want to see the embryos at about a 6-cell stage or above. So we'll phone you to let you know how your embryos are progressing. And then we just continue to leave them again to grow and divide until day 5. Now, just noting that between day 3 and day 5, we actually go from the embryos being about that 6-cell stage on day 3 to being roughly 150 cells on day 5. So they do undergo genetic activation steps, and this is often where we would see some attrition throughout a cycle. So when we do our day 5 checks to look at the embryo and see how they've progressed, what we're looking to see is that there are 2 different cell types. So what we're looking for is basically a compacted blob of cells in the middle of the embryo, which is what we call an inner cell mass. So these are cells that would go on to form the fetus. And then we're also looking for these other cells. So these are smaller sort of cells that we call trophectoderm cells, and they go on to form placental cells and supporting tissue. So here at Genea, we routinely do a day 5 embryo transfer. And by growing the embryos out to day 5, this just allows us to select for the best embryo with the best developmental potential for transfer. So that's something that's very difficult to predict at day 3. So what we'll do is, if you're having a fresh transfer, we will pick the best quality embryo for transfer, and then we'll assess the remaining embryos for freezing. Or if you are interested in doing the genetic testing, we will assess the embryos to see if they're suitable to have the biopsy done for the testing. Now, anything that's not suitable for transfer testing or freezing on day 5, we just give an extra 24 hours and then we reassess them for freezing or testing on day 6. So just moving on to our next slide. This here is our Gerdsen time-lapse incubator, and this is where all of our patient embryos are grown. So basically, I'll just press play as well. There should be a little video. So basically what our Gerdsen incubator is doing is taking photos of your embryos every 5 minutes in 11 different focal planes. So the instrument compiles these images together into a video of your embryo's development. And this just gives us a really comprehensive view of your embryo's development in the time that they spend in the lab with us. So the big advantage compared to many other clinics is that the embryos are left undisturbed during this developmental check. And there's now scientific research to suggest that not removing the embryo from culture has significant improvement on the embryo development and ultimately your pregnancy rates. So another really important component of the embryo culture environment is the culture medium. So this is the fluid that the embryos grow in, And we call this GEMS, which is our Genea embryo media suite. And it's proven to increase implantation rates. And we offer GEMS exclusively to Genea patients in Australia. So we use a single step media or a continuous culture media. So previously, we would have to bring the embryos out of the incubator to do their developmental checks and to check the media. But now that we have this single step media, which can support the embryos over the whole course of their development, we don't have to disturb them by bringing them out. So the combination of both GERI and GEMS has seen an increase in the number of high-grade embryos by more than 46%. So ultimately, these technologies support Genea's philosophy of helping patients to achieve their goal of completing a family in just a single stimulated cycle. Now, another great benefit of our GERI incubators, and this is probably one of the coolest advances for patient experience in the last sort of 5 to 10 years, is that in the first time ever in Australia, we can offer you the chance to see your embryos in pictures and videos. So this is through our own app. It's called Grow by Genea. And it's an app that we have developed for smartphones and tablets, which allows you to log in and see your videos and photos of your embryos for each night that the lab gives you a call with an update. So the feedback has been overwhelmingly positive, with the most common response being that patients feel more connected to their embryos, just at a time where they can often feel a little disconnected. So really just sort of puts that experience back into your hands. The other feedback that we've had is just that it really allows the partner to feel more involved in the experience. So often the person undergoing the treatment will be the one who receives the updates from the lab and will have all the communication. So it just helps both people feel part of the whole process, which is really nice. So with our GERI and GEMS, we're making many much more high quality embryos than we ever had before. So we need to have a way of freezing these embryos for later use. So there are lots of different freezing methods used throughout different clinics throughout Australia and throughout the world, but vitrification or rapid freezing is the most advanced technique. So current methods are very dependent on the skill and experience of the scientist. So Genea actually developed the world's first instrument that semi-automates the vitrification process. So this is our Gabby here, so the Genea automated vitrification instrument. And basically this provides the most consistent and standardized treatment of the embryos during the freezing process. It just maximizes the likelihood that the embryos will survive that freezing and thawing process to give the equivalent, if not a slightly better chance of success with a fresh embryo transfer. Okay, so just the last thing that I would like to talk about is another type of technology that's available to our Genea patients, and this is called GeneSure. So this is our pre-implantation genetic screening technology, so referred to as PGS. And this testing utilizes the next generation sequencing method to look at DNA. So it's the most advanced method and offers more precise information than many of the previous methods. So what it does is it allows us to look at all 23 chromosome types in each embryo, just to ensure that we are transferring an embryo that does have the correct the correct number of chromosomes. So basically, we do know that not all embryos have the correct number of chromosomes, and embryos that don't have the right number of chromosomes will most likely they'll fail to implant. But sometimes they will implant, but they can result in miscarriage. Or in a small number of cases, the chromosomal errors can result in the birth of a child with a genetic condition. So a condition like Down syndrome. So what this does is it just gives us an extra layer of embryo selection. So it ultimately allows us to get the embryo that's going to give you the best chance of success most quickly. And look, we know that time is of the essence, so this is a really useful tool that we have. I've just got one more slide if I can move that one along. So what PGS testing involves is us taking a small biopsy of the cells from each suitable embryo. So what we do is we take some of the cells from the outside of the embryo, so from those trophectoderm cells, the ones that would go on to form placental and supporting tissues. And we know that the embryo programs these cells to grow and divide rapidly. So the embryo doesn't mind if we take 5 to 7 of those cells. And it's just important here to note that we don't touch the inner cell mass. So those cells that would go on to form the fetal cells are not disturbed at all. Now, once we've taken the biopsy, those tissues are processed here on site at Genea, and the results come back within 3 to 4 weeks. And while we're waiting for those results, we just freeze the embryo using our Gabby machine. And then once the results do come back, we can have a look at those and choose the best embryo for transfer. Oh, sorry, I do have one more slide for you as well. So genetic testing can be an option for you if you are above 38. Just as we know that the success rates from IVF drop with increasing age, and this is in part because of the incidence of chromosomal abnormalities increases with maternal age. So another indication is for women with 2 or more pregnancy losses, as if this is of a genetic origin and the embryos are abnormal to begin with, then the pregnancy may not continue. It can be used if we have patients who have had a number of failed IVF cycles. So we might just be able to get some more information from the embryos as to why and see whether or not there's a genetic origin, rather than just looking at the grade of the embryos. It's also used with patients who have a history of genetic or chromosomal disorders, or just in a subset of women to basically increase your success in IVF in general. Okay, well, that's all from me. So I'll hand back to Dr. Marren.
Thank you. Just a couple of other things in regards to the embryology from a clinician's perspective. So obviously, like, the embryos sort of grow through to sort of day 5 or 6, and obviously we sort of grade them and work out which is the best embryo to go back and things like that. And look, if you transfer an embryo and it results in a pregnancy, then that's absolutely fantastic. That's what we want. But that's easy. What's really important is also for those people that aren't getting success. So the embryology will often sort of indicate sort of where the underlying problem is. And so embryo development to day 3 really sort of tells us a little bit about the quality of the eggs. And so our scientists sort of grade them 1, 2, and 3, so good, fair, and poor. Other clinics use a very similar structure. They often use A, B, and C, which is the same. Embryo development from day 3 to day 5 is then really reflective of the sperm. And as a bit of a rough rule of thumb, we expect about 50% to sort of drop off from day 3 to day 5. So if you've got beautiful embryos on day 3, and then your drop off is more than 50% from 3 to 5, then that makes us sit there and think, oh, there must be some underlying sperm issue going on. So it helps to sort of try to sort of diagnose what's actually happening. And then we can sort of look for things from the male side and how can we improve it and how can we get a better outcome. Or likewise, if the embryology is a bit sort of poor on day 3, then it really sort of indicates that there's an egg quality issue. And so again, so there are some various things that we sort of do. For instance, look for and treat any endometriosis before another cycle and things like that. So the embryology is not just egg and sperm getting together and getting to day 5 and us putting an embryo back. The IVF cycle is also a bit of a diagnostic test, and it really sort of helps to give us some idea of what's going on. And likewise with the chromosome screening, as I said, like even in our young population, so less than 30% of embryos will have a problem, whereas at 43 it's really high, it's 80 to 90%. And so having that sort of discussion about when it's indicated, are you going to test and freeze all embryos or transfer a fresh one and test the rest? That sort of discussion needs to happen with the fertility specialist. Once we have a nice embryo to go back, so we essentially do an embryo transfer. And this is a little bit like having a pap smear, really. So there's usually There's usually no sedation or general anesthetic required. You get the odd person that really does want that, and that's fine. But basically, we pass the speculum, clean the opening to the womb, and we just basically use an ultrasound on the outside, and then we basically just pass a fine plastic catheter through the cervix into the uterus, and inject the embryo. People can then basically get up, go to the toilet, go back to work. They can do whatever they like. Next slide, please. From the time of the embryo transfer to the pregnancy test, so because we do day 5 transfers, it's 11 days. And in that time, we're supporting the second half of the cycle. And there's a couple of ways in which we can do it. So it's either by some injections or some vaginal progesterone. And as I said, it's 11 days after the transfer or 16 days after the egg collection. The blood test is done, and every sort of doctor does things slightly differently. So essentially what I do is when I do a transfer, I sort of email my nurses and I email my secretary. We book in the blood test and my secretary books in a phone chat. So I basically have a phone chat with my patients on the day that they have their pregnancy test. And if it's all positive, then that's great. We just sort of tee up what's the next steps for them. Or if it's not, then we basically come up with a plan. All fertility clinics and Genea has sort of counsellors, and those counsellors are particularly sort of invaluable. So, and people sort of, use counsellors at various sort of different stages, but they are there and they're there to support you. And so sometimes even just having a conversation, even if you're sort of feeling sort of quite well, at least it then sort of establishes a link. So if things aren't going to plan, there is that support there, and it's someone that you are familiar with. Next slide, please. So essentially, there's a lot of people that's involved in the team. So it's certainly not just the fertility specialist, but there's obviously the nurses, the embryologists, the geneticists, genetics counselors, PGD scientists, the andrologists, the counselors, people from finance. So there's a sort of a big team, and certainly Genea in the city. So we're all broken down into sort of little teams, so that way our nurses can sort of get to sort of know the patients. Next slide, please. So in terms of success rates, and there was actually a bit of a question, I suppose, and I'll sort of bring it up again a little bit later, but it was just basically in regards to sort of success rates from Genea and sort of other clinics. So all clinics have had to sort of report their data to a group called ANZARD, and that data has traditionally come out in an annual report, and everyone's data was de-identified. So you can see how different clinics are sort of performing, but you don't know which clinic is which. And there's been a fair amount of lobbying, and in the last couple of years, your IVF success website has basically come out, and they basically list all fertility clinics. There are a couple of fertility clinics that have declined to have their results go up on it. So, if you sort of Google or enter into your IVF success, you'll sort of see that there will be a couple where their data is not there because they've refused for it to be published, but the majority have. And they've basically given a couple of different sort of measures, and they sort of compare the clinic that you're looking at versus a national average. And so, for instance, this one here is the births per completed egg retrieval. And that includes the fresh embryo transfer and then any subsequent frozen. So, for instance, if someone does an egg collection, they have a fresh and 2 frozen, it would include the live birth out of those 3 transfers, essentially. And so it basically breaks it down to those that are less than 35, those that are 35 up to 42. They don't really have data for greater than 42. And the blue is basically the Genea clinics, and the pink is basically sort of the national average. So you can just basically sort of see how the different sort of clinics perform. And obviously we're very proud of how our clinic is actually sort of performing. Next slide. This is basically the same as measure number 1, where it's the fresh plus the subsequent frozens, but what this is where women are actually having their first ever egg collection. And so you can see that the pregnancy rates are a little bit higher. And the reason why this is kind of important is because what we find in our clinic is that if you look at when do women take home a live born from their cycles at Genea, is it IVF cycle number 1, 2, 3, 4, or so on, we find that 95% of live borns come from egg collection 1, 2, or 3. Now, that doesn't mean to say that you can't achieve a pregnancy from 4, 5, or 6, but it sort of plateaus. And if IVF is going to get someone pregnant, it would normally get them pregnant within the first few cycles. And so this just basically sort of shows that if you're looking at their first cycle, then in the young cohort, 62.6% have a live born, and in the slightly older cohort, then it's 34.7. Next slide, please. So this is just births per individual treatment attempt, so it's per embryo transfer. And so again, they break it down less than 35, 35 to 38, and 39 to 42. And so again, you can sort of see that the Genea clinics are performing better than the national average. And then the final outcome, the next slide, please. Yeah. This is just per embryo that is transferred. And this has got to do with the fact that there are some clinics, for instance, that have quite a high double embryo transfer rate. So the issue with double embryo transfers is that you're more likely to get twins. And if you have twins, then there are higher risk pregnancies. So there's higher rates of miscarriage. There's higher rates of pregnancy complications like high blood pressure, diabetes, operative delivery, prematurity, higher rates of the babies not surviving, higher rates of cerebral palsy and things like that. And so some clinics may appear to have quite a good success rate, but it's because they're putting back more than one embryo at a time. Whereas this is talking about births per embryo. And so it helps to sort of sort that out when you sort of look through the data. Next slide, please. So when to seek help. So essentially, we're kind of happy to sort of see people at any stage. So you do see some people in rooms where they're like, oh, look, we think we've got to start trying in a few months and we just want to do tests just to make sure everything's fine and we just don't want to waste time. So look, we're happy to do that. You don't need to feel bad about coming for an appointment for that. We're not going to do anything that's super invasive or anything like that. And certainly just because someone comes and sees us, it doesn't mean to say that they're doing IVF the next month. And in actual fact, if you look at Genea consults, more than 50% of people who see a Genea doctor don't end up doing IVF. They end up doing other things first. As we sort of said, for those that are young, so less than 35, we'd say up to about 12 months. For those that are a little bit older, come and see us at 6 months. If you believe that there's a condition that's going to affect your fertility, for instance, you've had endometriosis or there's been an issue with a tube or whatever, then come straight away. Recurrent pregnancy loss, any genetic conditions, they're the times to reach out. Next slide, please. So what next? So essentially, essentially, I think your emails have sort of come through, and so the fertility advisor will basically sort of send out some information. There will be some, a pack that will come out. As I said, you either go off and see your own GP, or we do actually have fertility GPs at Genea, which will do a bulk bill consultation. And then obviously, depending on the outcome of all of that, then a review with a fertility specialist.